Hello, and welcome to everyone who is just starting to join us. We'll be starting in just about 3 minutes at the top of the hour. So hang tight and we'll lift off in just a couple more minutes. Hi, everybody. Thank you for those who continue to join us. We're starting in just about a minute and a half. We're going to give some folks some time to get settled in, and then we will kick off today's discussion. Okay, welcome everybody. We're getting a lot of folks who are just clicking through, joining us today. So I'm gonna give everyone about another 30 or seconds or so as we continue to see our numbers going up, and then we'll get started. So just a few more seconds here. We'll start right at about 1:01. Okay, we're gonna go ahead and get started. So welcome everybody and thank you for joining us. It is April 1st, 2021, no fooling. And today's physical health and primary care lens on sleep assessment and intervention. It's our 5th episode of the Solving for Sleep series. The series is made possible through PCDC's partnership with the SAMHSA Center of Excellence for Integrated Health Solutions. And we thank them and you for your support in this series. Next slide. So if this is your first time joining us, I'm Andrew Phillip. I'm a clinical health psychologist and the clinical lead and senior director for partnerships here at the Primary Care Development Corporation. Next slide. So again, if you're new to us, Primary Care Development Corporation, we're a national nonprofit organization founded over 20 years ago, really with a fundamental mission to enhance health equity in underserved and frankly, disinvested communities. And since 1993, we've done this through capital investment to the tune of over $1.2 billion to enhance healthcare infrastructure around the country, through advocacy, through research to build policies that actually support this enhanced infrastructure and sustainable primary care services where they're needed most, and through training and technical assistance like today's webinar, as well as consultation on everything from patient-centered medical home, accreditation to primary care behavioral health integration, HIV prevention, care management, reproductive health, and more. Next slide. So just a quick disclaimer I will offer. The views discussed today and really throughout this entire series are those of the presenters and do not necessarily reflect those of the Center for Mental Health Services, SAMHSA, Health and Human Services, or any other federal entity. Next slide. So let's hop to it here. So in this series, again, if you're new to our series or a refresher if you're joining us again, the series is really designed to further the whole movement of physical and behavioral health integration to enhance access to services with really this whole person biopsychosocial approach to care. So we're honing in on this like universal need or pain point for some, which is really sleep. We've been examining different aspects of sleep from impacts around mood, health, overall well-being, but also the role of care teams in listening to and partnering with patients really to enhance sleep health and to develop almost like a core set of tools or skills to help in this area. Next slide. So earlier this year, we, and this is actually this is our 5th episode, as I mentioned, and you'll see the others here on the screen. We'd started the year by reviewing kind of the foundational components of sleep health. Later, we heard from researchers and healthcare leaders on what they've been seeing, especially around addressing disparities and inequities in access to sleep health and care. We talked about the behavioral health side of assessment and treatment for insomnia. And even just last month, we had a really interesting panel of experts about their own lived experience and quite human experiences around managing sleep health from a patient perspective. And in May, so at the end of our series here, you'll see on the 6th, we'll be wrapping up with a session called What About Us or Just About Us, and it's really dedicated to those of us who are actually in healthcare provider or caregiver roles, focusing on the importance of addressing our own sleep needs. But today, we're centering our time and our interests in what many of you have been bringing up throughout the series, and that's really a desire to learn a bit more about the medical and physical health side of sleep health. We've mentioned things like sleep apnea, but what is that? What does it mean? And how can we, as either physical health or behavioral health or other types of healthcare folks, really incorporate this knowledge into our work? One of the most popular questions, I think, since day one of our series has been like questions around like, what is sleep apnea? What's that all about? The ever-present question of what's the deal with melatonin? So we're going to talk about these things and more today, and really about how physical and behavioral health providers can work together and more. So we have 90 minutes today, including some open time towards the end of the discussion, as almost like an office hour to go over any questions that you might have, but also to hear from you and what perspectives you've had and what your experiences are. So today's session is being recorded, as they have all been, and will be available on our website at pcdc.org/sleep. And today's episode should be up in the next couple of days, and we'll send out an email as it becomes available. But you can also head over there to see all of our other episodes too. So next slide. So just before I introduce our guest presenter, I'd like to hear a little bit more about you. So we're going to pull up a poll. Let us know who you are, basically. What type of setting do you work in? Do you feel like it's more of a kind of primary care setting, more of a behavioral health-centric setting, an integrated setting, or something else? And if you're in either of those, we definitely want to see. You've got a chat box that you can use there. You can select all like panelists and attendees so everybody could see. Let us know where you work, especially if it doesn't fit into one of these neat boxes. And also, we're curious, what do you do? What sort of discipline do you come from? Are you a physician? Are you a nurse, a nurse practitioner, a medical assistant, a therapist, social worker, care manager, other? And again, I'm especially interested in our other categories. So use the chat. Let us know, what do you do in addition to where you're calling in from and what type of work you do. So thanks to the folks who have been chiming in there. So we'll leave our poll up for just a few more moments. We've got a pediatric psychologist, health promotion, higher ed, awesome. Ooh, voc rehab counselor in Southern Illinois, welcome. Program specialist for the government, federal government, very nice, welcome. Oh, we've got more. We've got folks from National Institutes of Health. Excellent. Glad to see you here. Mental health recovery services. Excellent. Neuropsychologists. Nice to see. Oh, peer specialists. So gosh, we really need you folks and value your perspectives. Oh, excellent. We've got folks from senators' offices. We've got people with social work backgrounds now going to healthcare work, dental therapy. Excellent. Very nice. Folks from Canada bringing an international perspective. Welcome. Human services. Keep them coming. So, Chaim, we can probably bring up the results for our peer as we go. HIV peer navigator. Nice. We've got folks from health departments. Okay, so where are you? You're largely in integrated care settings, 46% of you, but otherwise it's almost a pretty close split between primary care and behavioral health. Really nice to see, in addition to our others who have mentioned. And our audience is really, I'm always excited to see this. So we've got folks who are kind of we've got some RNs, we've got therapists, social workers, but also a lot of you who are in the other category, and that's what we're seeing here. So I always get particularly excited to see folks who don't quite fit into our neat little boxes, because it's just so helpful to see substance use. Nice. Okay, so we'll hop over to our next slide here. And really, without further ado, I'd like to introduce Dr. Meena Khan. So Dr. Khan is an associate professor of clinical medicine at the Ohio State University Wexner Medical Center. She completed medical school as well as her neurology residency and sleep medicine fellowship at the Ohio State University. Currently, she's also the program director for Sleep Medicine Fellowship Program, as well as the co-director of the annual OSU Sleep Symposium. Her clinical interests include neuromodulation for sleep-disordered breathing and sleep-disordered breathing in neuromuscular disease. So we're definitely going to hear about some of these things and more. Dr. Khan, it's an honor to have you here. Please take us away.
Thank you for having me here. I'm going to share my screen here. Can you guys see that okay?
Yes, looks good.
Okay. So thank you for having me here this afternoon. I'm going to talk to you today about insomnia and about sleep apnea, kind of from a sleep medicine perspective, and then how we may integrate with behavioral medicine and other areas to kind of help take care of these patients, because sleep is a multifaceted issue that can be managed and improved from multiple aspects. So first of all, I'll talk about insomnia. So insomnia is pretty common. About 75% of the general population has a sleep problem at one time or another. Over 50% of people who were screened in this survey said they had some sort of insomnia over the previous year, and a third report nightly symptoms. Insomnia is correlated with a decreased quality of life, increased mental health symptoms, issues with having to call off work, issues with decreased work productivity, increased use of medical resources, and economic burden. So it does affect people in multiple different ways. But unfortunately, a lot of times it's not addressed very well in the primary care setting. Either the patients may not mention it, or it's not something that's the focus. You know, when you're dealing with other things, like high blood pressure and diabetes and maybe other chronic medical issues, to spend the time talking about sleep doesn't always fit into an office visit. In addition to issues with quality of life and work productivity and mental health, there's also associations with increased reports of heart disease and high blood pressure, development of depression and anxiety. So while people who suffer from depression and anxiety can have insomnia related to their mood, there's also been evidence that shows that people who have insomnia have a higher risk of developing depression and anxiety. And while treating the mood symptoms doesn't always correlate to improved sleep, improving someone's sleep usually correlates to improving their mood symptoms. So, you know, rather than having the thought that, well, if we improve their depression and anxiety, their sleep should just get better, that actually is not true. Whereas if we improve their sleep, their mood can significantly improve. So what I'm going to talk today is the two-process model for sleep, or how do we sleep. Talk about cognitive behavioral therapy and how it improves insomnia. And I know that you've already learned about what cognitive behavioral therapy is, so I'm not really going to go into what it is, but more how that can help us with helping patients sleep better, and how that feeds into and how we sleep naturally. and then the potential role for pharmacologic intervention for insomnia. So the way we sleep depends on two things. One is we have a circadian drive or a biologic sleep drive. So there's times where we're naturally sleepy and naturally alert. And then there's also what we call the homeostatic drive for sleep. So the longer we're awake, the more the need for sleep that we have. So as a question to you, what do you think influences your circadian clock or your sleep clock the most? All right, great. So light definitely influences our clock the most. Eating and physical activity also influences our clock, but light is the strongest, what we call Zeitgeber, or something that entrains our circadian or sleep clock. So whenever with our circadian or our sleep clock, it's a biological clock, and it's housed in our brain in something called the hypothalamus, which is kind of in the center of the brain here. And basically, there's a natural time, usually in the morning, where our alertness level increases. And then after noontime or after lunch, so around this time actually, there's a dip. So this is why we feel sleepy after lunch and can feel like we can take a nap. In some cultures, they actually do take a nap. And then you kind of get a second wind where your alertness increases, and then there's a dramatic drop sometime at night. And the nadir usually, or the lowest point of alertness, is anywhere usually between 2 to 4 a.m. for most people. And then, it starts going up again. And our circadian or our biological clock is actually a little over 24 hours. So our environmental clock is 24 hours, but biologically our sleep clock's a little over 24 hours. So what that means is if you were put in a dark room, and they've done these kind of studies in people, if they put someone in kind of a dark setting without any daylight influences, without any kind of daily activity influence, people will go to bed later and wake up later every single day. And so that's why it's easy for us to stay up late and wake up late, but it's not so easy to go to bed early and wake up early, because biologically we're prone to getting up later and staying up later. And so what we use are these things called Zeitgebers, or environmental influences, to make our clock to the 24-hour clock. Light being the strongest one. So light when we're awake, darkness when we're sleeping is what is the strongest clue to our brain of what sleep cycle we want. And when we're doing things like hanging out in dim light all day or having lights on at night when we're trying to sleep, that messes up our biological clock, and they don't really know, it doesn't really know a distinction of day versus night. Other things like eating, activity, social cues are also helpful. So if someone doesn't have a lot of structure to their day, they kind of get up and go to sleep whenever they want, they're going to have an irregular rhythm, or maybe this delayed where they go to bed later and wake up later every day, and they may say something like, well, I've always been a night person, but now I'm not falling asleep till 6 a.m. And it's probably because they're going with their natural biological clock and not in training to a 24-hour clock. Another place you might see this is someone who has dementia, who's not really able to set their own daily schedule, or someone who's born with developmental delay or cognitive issues where they can't set their own sleep schedule, and they're kind of, sleeping erratically. And sometimes caregivers will say they're up all night and they're sleeping all day. It's because they're not really in any kind of a cycle, because they don't have any schedule. And so if they can't set their own schedule, it would be up to the caregiver to try to set a schedule for them where they're not disturbed at night, and during the day they have set activities or some sort of interaction going on to keep them engaged when they want them to be awake. The other thing is our homeostatic drive for sleep. So the longer we're awake, we build up this chemical called adenosine. So the more adenosine, or the higher your adenosine level, the stronger your need for sleep. And then when we sleep, that sleep need drops off. So actually caffeine acts by being an adenosine receptor blocker. That's how it promotes wakefulness. So if you're doing things, or someone's doing things like getting up later or taking naps, you're kind of blocking that sleep drive. And when you're blocking that sleep drive, that can affect someone's ability to then sleep at night when they want to sleep. So, ideally for us, the ideal time to sleep is when our alertness level is low, and our sleep drive is high. So this would be the ideal time to sleep. If we can sync things up so we're, syncing up our sleep drive to be the highest when our circadian or biological clock alertness is low, then usually sleep is pretty good. The issue comes in when people are trying to sleep when they're not tired. So they're going to bed, maybe they go to bed at 9:30, 10 p.m. and they're like, I'm not sleepy, but I'm just going to bed because I feel like that's the time I should go to bed. So their circadian clock isn't really at the lowest it should be, or as low as it should be to promote sleep, so they're having trouble sleeping. And the other thing is they could be delaying their sleep drive by getting up later. So, they don't fall asleep till 2, 3 a.m. So they don't get out of bed till maybe 10 to noon. And so they're blunting the beginning of their sleep drive. So instead of starting at 6 a.m. and starting here at maybe 10, then maybe they lay down and take a nap because they're sleepy, and that blunts it even more. So then when they want to go to bed, their sleep drive is down here as opposed to up here. And so they can't sleep and they need more time. And then it's, 2, 3 a.m. maybe before they can really sleep. So people with insomnia have difficulty initiating sleep, maintaining sleep, or having good sleep quality that occurs despite adequate opportunity. So these aren't people who are sleep deprived, like they're going to bed late because they have other things to do. These are people who are in bed for significant amounts of time, but they aren't asleep for the majority of that time. And then there's some sort of daytime impairment. So there may be people that it takes them 2 hours to fall asleep and they wake up in the middle of the night, but they feel like they function fine during the day and it doesn't really bother them. That's not really insomnia. Insomnia is if it bothers them. If it doesn't bother them, then I don't know that needs to be changed. But if they're having daytime impairment or anxiety because of it, then it's something we should address. So again, question to the audience. When treating insomnia, which one of these do you think is true? Medical management alone is the first line of therapy for insomnia. Cognitive behavioral therapy for insomnia alone has better short-term improvement compared to medicine management alone. Or CBTI with medication management has the best short-term effect, with CBTI alone showing more long-term benefits. I'll give you about 30 seconds. All right, great. Yeah, so CBTI in combination with management in the short term has a good outcome with weaning the medication off completely or maybe intermittent use and using mainly CBTI for more long-term benefit. In studies that's shown to be effective, in real life, sometimes it may be difficult to convince a patient to stop a medication if they feel like it's helping them. But there's a role for combination therapy in the short term. One of the things I want to show you guys is this sleep diary, which a lot of you may be aware of. This is from the American Academy of Sleep Medicine, so you can just Google it and download it offline. So this can be helpful in just having a patient document what's their sleep schedule like, or what's their sleep pattern like. So I like it because they'll basically shade in when they think they're sleeping. They'll write E for when they exercise, A if they drink alcohol. This line is when they go into bed, so you can see they're getting into bed and then they're not really sleeping for a couple of hours, and they sleep and they're up for an hour. And then if they take caffeine or any medications, they'll mark that with a C or an M. And you can get a lot of information. So if you don't have time to sit down and talk to them about it, let's say the patient's just saying, I have a sleep issue, and you're kind of at the end of the time you can talk with them, you could give them the sleep diary to fill out and come back at the next appointment to go over. And it can give you a lot of information. You'll be surprised what people are doing and not realizing, and how much time they're spending in bed, how irregular their sleep pattern is. They're drinking caffeine up until 10 o'clock at night. They may be drinking a lot of alcohol, which could affect their sleep. So it can give you a lot of information, and then it's on the patient to fill out rather than you having to sit there and talk to them, which can be a time saver if you're crunched for time or have multiple things you have to address with the patient during your time with them. I think it's also helpful if you're doing some sort of behavioral or sleep treatment to see the improvement, because patients can't always remember night to night what happened, but they could track this and kind of see over time, even for themselves, that things are getting better. So even if they themselves don't feel that whatever you're doing is helping or the therapy isn't helping, but you can see objectively, well, your sleep is more consolidated than it used to be, even though maybe it's not quite what you want, that may give them some confidence in what's going on with their treatment as well. So, cognitive behavioral therapy is really the best way to treat insomnia. And as a sleep medicine doctor, this is what we push. We actually write very little sleep medications. I'll talk here in a minute about when a sleep medication might be helpful. But in general, sleep medicines are not a long-term fix. If anything, it's a short-term fix. And in sleep medicine clinic, we've probably seen patients who've already tried medications already and it's not helping. So usually the situation is that it helps, but then you develop tolerance. You need more medications or higher doses, and they've tried 5 or 6 medicines and they still have insomnia. Or if there's someone where it actually does help for a long, for a decent amount of time, they can't sleep unless they take it. And that's because the medicines don't really affect the 2-pronged model of sleep. They don't affect your circadian drive and they don't build your sleep drive. And so that's why they're probably not really effective in the long term. Whereas CBTI, or cognitive behavioral therapy, does affect those. So with the sleep restriction you learned about before, where you limit your hours in bed to your time sleeping, so you have a high sleep efficiency, that helps build sleep drive. If you're spending a long time in bed, most of it not sleeping or very little of it sleeping, you're really blunting your sleep drive. If you're getting up late, taking naps, that type of thing. Influencing your circadian clock, so making sure that during the sleep time it's dark and that there's a lot of light exposure during the wake time. So the bigger difference there is between light during the day and darkness at night, the stronger the sleep clock is going to get entrained to whatever sleep schedule the person wants. If they're kind of in dim light all day and not much difference at night, it's not getting that distinction. If they have a lot of lights on during the sleep time, whether it's in their house or external, we have a lot of external lighting. They've shown like satellite pictures of the Earth at 2, 3 a.m. and there's lights everywhere. So it could be external. Maybe they need to get blackout curtains. Maybe they need to do blackout blinds for their eyes. This is important in people who have shift work disorder, where they're trying to sleep during the day and it's naturally light out, to get as much darkness as they can. And if they're in a good working environment when they're working nights, they're working in a bright light environment during their shift to help with that sleep cycle. Stimulus control is training your brain to expect sleep only in a certain area. So you only want to sleep in your bed. You don't want to sleep in other places. And you just want to have your bed for sleep. So we say the bed should only be for sleep and intimacy, and everything else should be somewhere else. You shouldn't be doing work in bed. You shouldn't be checking your email. You shouldn't be on your phone. You shouldn't be doing other things. In that way, your brain is building that relationship with the bed and sleep. You also don't want to be awake a lot in the bed because, again, you're trying to build that relationship with bed and sleep. So, for example, when we look at a bathtub, we usually think about taking a bath or a shower. We don't think about going there and eating our dinner or going to bed there, because we don't do that there. At the same time, we want our brain, whether we realize it or not, to look at our bed and think of sleep. And having a set bedtime and wake time helps with that. The more entrained you do that, the more your brain sees that. It's like 11 p.m., that's the bedtime. 7 a.m., that's the wake up time. If you keep that every night, within, we'd say, a half hour to an hour or so, your brain will, those times and the bed and that will be automatic cues to your brain for sleep. And the more routine and the more structured someone is with that, the faster their brain is going to learn that. And then sleep hygiene. So sleep hygiene is important. In terms of all the things with cognitive behavioral therapy, sleep restriction and stimulus control actually are the most effective. Sleep hygiene is important. If you're drinking caffeine until 11 o'clock at night, you're probably not going to sleep. But there are a lot of people who have good sleep hygiene who still have insomnia. So while sleep hygiene is important, it typically doesn't fix insomnia alone. And that's typically the most common thing people will read when they look things up on the internet. Don't drink caffeine, don't watch TV in bed, try to exercise, things like that. But people can do all that and still have issues with their sleep. So stimulus control and sleep restriction are actually the most effective therapies to help people with insomnia. In terms of sleep hygiene, I always make sure I ask patients about their caffeine intake, about their alcohol. So caffeine can last 10 to 12 hours in our system. And I think sometimes people underestimate how much it could be affecting them. So usually I say try to cut it out by 1 o'clock if you can. Alcohol, it may help someone fall asleep, but it fragments their sleep the second half of the night. So it takes about, I think, 1 hour to metabolize 1 unit of alcohol. So a glass of wine, I think, is 1 or 2 units of alcohol. Beer is 1 or 2 units, and then with each drink, that's more and more units. So usually if something like, nightly alcohol is a part of someone's life, if they can limit it to 1 to 2 drinks and finish it 4 hours before bedtime, it probably is going to influence their sleep less. Nicotine, sometimes people smoke at night because they feel it relaxes them, but nicotine is a stimulant, and studies show that people who use nicotine have more sleep issues than people who don't. So in general, we advise to not use nicotine at night if we can avoid it. And then exercise helps sleep no matter what. No matter what time you do it, no matter when you do it, it helps sleep. So whenever you can fit it in, we encourage our patients to fit it in within reason of what they can do. So sleep medications, when do you think of a sleep medication? So if someone has high anxiety, high stress, they have a lot of things going on at work or at home, and they just can't get their mind to shut off, and they're doing all the behavioral therapies and they still can't fall asleep, then maybe there's a role for a sleep medicine to kind of take the edge off to help them sleep. But just keep in mind, this doesn't change your circadian clock. It doesn't change your sleep drive. Sedation isn't sleep. So if all the person does is take a medication, more than likely they're not going to get the effect that they want, or if they do, it'll be short-lived. Also, things like benzoreceptor agonists, things like zolpidem, those are associated with things like sleepwalking and sleep driving, and really DBTI is the primary recommendation to help people with their insomnia. If you are going to do a sleep medicine, let's say you have a patient who's really stressed, really anxious, and you feel like, I think maybe this would help them, and they do have good sleep behaviors, but they just, can't get to sleep. When they take it is important. So you want them to take it when, their sleep drive is high and their alertness is low. And then this is going to help kind of give them that edge to fall asleep. If they're taking their medication when their sleep drive isn't high or their alertness level isn't low, it's probably not going to do anything. So people say, I take my trazodone at 8 p.m. and it takes 5 hours for it to work. Well, it's probably not true. 5 hours, obviously the medicine level hasn't just escalated. It's probably that's when their sleep drive and their circadian clock were aligned where they could fall asleep. And the medicine probably doesn't really have much to do with it. So if you're going to do a medication, I would try to make sure they're doing the right scheduling and things like that and taking it maybe 30 minutes before they plan to go to bed. So it helps actually promote sleep, as opposed to taking it when their body's not ready to sleep. It's probably really not doing anything. So things to keep in mind: half-life of medications. So if you're going to restrict someone to so many hours in bed, you probably don't want to put them on a medicine that has a half-life of 10 to 12 hours, like some of the sedating antidepressants or sedating antipsychotics, because you're going to set the patient up for morning hangover. And then also, what is your goal? So if you're treating pain with insomnia, you want to use something like gabapentin. You're treating mood with insomnia, so you think trazodone or mirtazapine might be helpful. What is your goal with the medication? If your goal is, I don't really want to do this for the long term, you may want to think about just really looking at behavioral changes, especially for someone who's maybe has an erratic schedule and does take naps and drinks a lot of caffeine. They may find a lot of improvement just by doing some behavioral changes, and you don't really need to do a medication. And if their anxiety is mainly about their sleep, then maybe the treatment would be to try to improve their sleep with behavioral changes rather than putting them on a medication. So it's just things to think about. Again, there are roles for medicines, but it's just some things to think about in terms of guidelines of how to use it. So these are the different FDA-approved hypnotics. So benzodiazepines in general, we try to stay away from for reasons of addiction and tolerance and things like that. But if you are going to use it for sleep onset, these are temazepam is something that sometimes can be used because it's shorter acting. Zolpidem, zolpidem, escalflone. These are the benzoreceptor agonists, which can be used for sleep onset insomnia. And then other classes were Melatonin, which is a melatonin receptor agonist. Suvorexant, and Liborexant are actually different than other sleep aids. Most sleep aids are trying to promote sleep, cause sedation. Suvorexant and Liborexant are actually orexin antagonists. So orexin is a medication is a neurotransmitter that's wake promoting, and actually blocks that. And so it's trying to block wakefulness as opposed to promoting sleepiness. So it's a different way to treat insomnia. So these can be used for sleep onset insomnia. Middle of the night awakening, so someone has no trouble falling asleep, but they wake up and have trouble going back to sleep. You want to use something short acting. So Zlephalon or Zolpidem IR, there's a low dose that you can use, and there's some brand names that have really short half-lives that you can use for the middle of the night awakening. Sometimes insurances don't cover those, so that might be another problem with that. And then sleep maintenance, someone who has a lot of awakenings during sleep. Zolpidem extended release can be used. Ascopiclone can be used. Again, suvorexant, lamborexant can be used. And then doxepin. So doxepin is an old school medication, but it was recently, well, not recently, I guess 5 or 6 years ago, was approved in a different formula. The brand name is Tylenol, which is a 3 to 6 milligram dose for sleep. And actually this was tested in the elderly and found that it was efficacious in the elderly and didn't cause harmful side effects. But it's at this 3 to 6 milligram dose. So it's not the typical doxepin, the generic form. It's this new branded medication called Tylenol. These are some of the sedating antidepressants, and sometimes people use these because they feel that it's safer. And while maybe part of that may be true, a lot of these have longer half-lives. They don't have a lot of studies that show that they're efficacious for sleep in particular. They may be sedating, but whether or not they're really been looked at to help sleep as a primary disorder, for most of these, the literature doesn't really support that strongly. But there may be roles for it. So someone has mood, like depression or anxiety, maybe using something like trazodone or mirtazapine can be helpful. If they have headaches or chronic pain at night, amitriptyline might be helpful. So there may be roles where it's doing some sort of dual therapy and you could try it, but they do have longer half-lives. They can have more side effects. And so it's just something that you do want to kind of look out for. So melatonin, a lot of people, like melatonin, feel that it's natural, and so they feel better about using it. From the American Academy of Sleep Medicine, there's not really a recommendation to use melatonin because there isn't a lot of evidence. Now, it might be that there's not a lot of evidence because people aren't really doing robust studies on melatonin. And so that might be the reason for that. And the studies that were done were on a 2 milligram dose. Melatonin can go up to maybe 10 milligrams. So it might be that the studies just aren't there, not that melatonin isn't effective. And likely it's fine to use in the short term. We don't have studies that show us what the long-term effects of melatonin are. And generally the half-life is pretty short. So maybe it would help someone fall asleep, but not help someone stay asleep. Also in the elderly, people who have cognitive issues, there have been some studies that have shown that this can cause more behavioral problems and confusion and issues like that in that patient population. So you do want to be careful about that. So in general, if a patient asks, can I use melatonin? I don't tell them they shouldn't use it. They can use it. I let them know that it is short acting. They should probably take it 20-30 minutes before they go to bed. They shouldn't use more than 10 milligrams. So don't use 20-30 milligrams because you think it's safe, because it's a natural sleep aid, quote unquote. So there may be some role for its use, but there isn't a lot of evidence about how effective it is. And then there's a resource here in terms of the ASM clinical guidelines for pharmacological management of chronic insomnia. If anyone's interested, there's some tables. There's some of the tables in this talk came from this article in terms of what's recommended for sleep onset, sleep maintenance, insomnia, and things like that. So next I'm going to go to a case presentation. So this is a 35-year-old male complaining of trouble falling asleep and staying asleep. He's exhausted all day and tries to nap but cannot sleep. He's tried everything he can to help him sleep, including medication, not meditation, including medication, over-the-counter sleep aids, and what he has read online, but none of it works. His PCP has tried trazodone, zolpidem, doxepin, and suvorexant. None have been effective. He's worried about his health and that he's going to lose his job due to being so tired from lack of sleep. When you talk to him about his sleep behaviors, he goes to bed at 9, but he can't fall asleep until midnight, sometimes later. He gets up a few times and he feels it takes forever to fall back asleep. He lays in bed in the morning until about 10 a.m. Because he's so tired. He drinks coffee in the morning and soda in the afternoon. He stops at around 5 p.m. And then he does lay down during the day for an hour or so but he cannot sleep. And he lays down because he's tired from not sleeping at night. So that's a pretty typical patient we'll see in sleep clinic with insomnia. It's a pretty typical history. So can you identify behaviors in our cognitive processes that may be counterproductive to this person's sleep? And I think that there could be like an open chat for this or just enter responses.
So we've got folks starting to chime in. We've got some cutting back on sleep, or rather on coffee or soda, better sleep hygiene, caffeine way too late, laying in bed until 10 a.m. They identified laying in bed at night when they're not able to fall asleep. Wendy mentions anxiety as well on top of the soda. Roberta's mentioning going to bed too early. A lot of folks are mentioning caffeine. Cecilia also mentioned napping. Yeah, we've got, Marie mentioned the pop of the caffeine, Jacqueline mentioning just that early bedtime as well. Oh, and anxiety. Nurse Kay has mentioned the anxiety as well.
Yeah, so these are all contributing, right? So he's in bed, basically this person's in bed from 9 p.m. till 10 a.m. So that's 11 hours. You're not going to sleep 11 hours, so they're going to be awake. And sometimes, when you spell it out to the patient like that, hearing that perspective on it makes them think about it. When they're living it tonight, they probably aren't thinking about it that way, right? But definitely a lot of time in bed, laying down. And sometimes if you don't ask patients, are you resting or laying down, they'll say, if you just say, are you napping, they'll say no, because they can't sleep. They lay there, but they can't sleep, but they're actually, inactive for a good amount of the day. Underestimating the effect of caffeine. Sometimes people say, yeah, I drink caffeine with dinner, but then I stop it in plenty of time to go to sleep. As we said, it can last 10 to 12 hours. So, not underestimating the fact of that. And then sleep anticipatory anxiety. So that's very common in people with insomnia. I mean, pretty soon after having a few nights of bad sleep, some people get really anxious when nighttime comes, that they're not going to be able to sleep. And then they're thinking about all the terrible things that are going to happen the next day. And then the next day, anything that happens that may not go right, it's all because they didn't sleep. It couldn't be due to anything else. It's all because they didn't sleep. And then they have these catastrophic ideas. So then there starts to be anxiety and cognitive barriers to being able to sleep. So what do you feel is the next step for this patient? Sleep study, referral for cognitive behavioral therapy for insomnia, trying mirtazapine to help insomnia and possible comorbidity disorder. Great, yeah. So this is the step that I would be. So I'd probably work through, some behavioral things, tightening up the time in bed, telling them to cut out or reduce the naps, scale back the caffeine, to try to approach the patient, try to improve things. And then, if things aren't really going as I would like, and especially if the cognitive barriers seem very pronounced, the anxiety about sleep, the consequences. And sometimes you have patients who are asking, am I going to die because I'm not sleeping enough? I feel like those are best served to go through maybe a formal CBTI program with a trained psychologist that can maybe do more frequent sessions, more cognitive therapy and that type of thing with the patient to really help them with their sleep. So I'll turn it over to Dr. Phillip here and see what his thoughts are from a behavioral perspective. I think this is like a great example of how sleep medicine can interact with behavioral medicine to really help improve these patients here.
Yeah, thanks, Dr. Khan. And I think I really appreciate, and I think a lot of folks in the audience do as well, you're highlighting that in a lot of these cases, medication or things like that aren't necessarily the first things we may consider. Although, again, realistically, lots of people will have cycled through numerous options. And a lot of the times, for me as the health psychologist or a member of a primary care team, that's usually where they'll sort of get funneled to me, is because it's like we've tried numerous medical interventions. They don't seem to be responding. And I think the audience really, a lot of the folks who were chiming in on the chat here mentioned some of the key things. What sticks out to me is that, and you highlighted it too, that catastrophizing, right? It's taking me forever to fall asleep. You could just hear the intensity when someone says that. And then the way that individuals connecting it to the fear of their job loss, even like the stakes suddenly, and you did a great job also of mentioning a lot of the patients that we see, they do connect sort of their function the next day with how they slept. And so it's like, oh, if I don't sleep tonight, I'm going to do a terrible job at work tomorrow. Or I've worked with athletes who worry about their physical performance and those high stakes. So suddenly sleep becomes not just this experience where we're falling to sleep and it's sort of this nice process, but the pressure is on. And that's where, and I love that you highlighted the anticipatory anxiety. Even just the idea of going to sleep becomes so stressful. And so from a behavioral perspective, I think those are what I listen for. Are not only do they have those symptoms of insomnia, like you said, it's not a passing thing. It's not something where they're just some people we know just don't have the same sort of sleep need. But are there those behaviors? And that's what I think a lot of the folks in the chat have mentioned, that they're just clear. We know, they're I was kind of joking around with some folks in the chat about doom scrolling, but that's been a real thing this past year. Some of our folks with lived experience highlighted that. But are there things they're doing behaviorally that just we know aren't great for sleep? But then from a cognitive perspective, are there some maladaptive beliefs or maladaptive thoughts that are just not doing them any favors? And that's something that I've had to, that a lot of the folks I've treated have really found reassuring when we talk about, look, in general, your body's not going to let you die from lack of sleep. It will eventually get the sleep it needs, whether it forces it on you when you're sort of, trying to wake up in the morning, or you doze off watching a movie or what have you. And then also that usually a couple of bad nights, and actually I'm curious if you can confirm this, because I may have been making this up, but it seems like a few nights of bad sleep or a rough sleep aren't going to significantly alter our performance. It's more so what we do worry about is the long-term effects of poor sleep. And that's also how when I receive patients who have been prescribed something like Zolpidem or Ambien or those things for long periods of time, and they feel like that's the only way they can get through, sometimes the conversation or where the change comes in is talking about the quality of the sleep that they're getting on that. And you mentioned benzodiazepines as well. And so, we get very tied to those things, but a sort of aha moment is sometimes talking through, it's not just the fact that you're passed out or you're unconscious or you don't remember not sleeping, but it's the quality of sleep you're getting. And if we can sort of operate on some of the behavioral principles, we can make sure that those few hours of sleep that you're getting are actually better quality. And so it's things like that. Like I look for kind of what are the hooks, because it's hard work. Even the sleep diary you mentioned, that takes some effort. So that's sort of my thoughts. And then usually when we go through that, we do a course of CBTI or even a brief intervention around that, and it doesn't work, and I think this is where we might be going, I start to detect that there may be something else going on. For example, they're having unusual physical experiences, heavy snoring, waking up gasping, choking for air. Then I start to think maybe actually there is a medical underlying component. And so at that point, I'm probably reaching out and saying, Dr. Khan, hey, I've got this patient. We've done a successful course of a behavioral intervention, but they're still really struggling, or their daytime somnolence is very high. Now I'm getting worried that there's a much more complex issue. And so that's usually when I'll bounce them back for something like a sleep study. And I know I don't want to spoil the fun on that, but those are some of the thoughts that I have.
So that's really great. So a couple of things actually that I thought of while you were talking is, a lot of times it shows, and studies have shown with people with insomnia, they actually sleep more than they realize. So they kind of underestimate their total sleep time. So usually when you talk to them during their wake hours, they're tired, but they're not dozing off. So typically if you're sleep deprived, you're going to fall asleep. That's why people who have sleep apnea, obstructive sleep apnea, doze off during the day, because physically their sleep is being interrupted by their airway closures. And so they're not getting the sleep they need, so they fall asleep during the day. So if an insomnia patient says, I'm falling asleep during the day, that definitely makes you think, oh, maybe this is more than just insomnia. Because most insomnia, pure insomnia, uncomplicated insomnia will say, I'm tired, but I can't sleep. I lay down a nap, I can't sleep. Whereas if they're saying, yeah, I doze off quite a bit, that makes you think there's something else. And from sleep disorders, the most common thing we screen for is sleep apnea. And in somebody who they're doing the behaviorals, it doesn't seem to be the cognitive barrier. They seem like they're sleeping enough, but they're still really tired or sleepy during the day. We may do a sleep study on them too, just to make sure we're not missing something, because in some patients, the presentations of sleep apnea may be insomnia and fatigue and not so much snoring, choking, gasping, and falling asleep, especially in women and in the elderly. So that will lead us to our next topic here, which is obstructive sleep apnea. So obstructive sleep apnea is an increasingly common condition. It's currently estimated that it may affect 1 billion people worldwide. Moderate to severe obstructive sleep apnea varies per age group, but it's estimated to be as high as 17% for men and 9% for women in the United States. We need to define it as an apnea-hypopnea index greater than or equal to 15 per hour. So at least 15 times more per hour where their airway is either completely closing or narrowing enough for their oxygen to drop or cause an arousal. And untreated sleep apnea leads to disrupted sleep. It's associated with daytime sleepiness, also with decreased quality of life, but especially severe untreated sleep apnea is associated with things like cardiovascular disease and insulin resistance, dyslipidemia, and death independent from other risk factors or all-cause mortality. So what we'll do in this second session or second half of this is to talk about obstructive sleep apnea, the health consequences of untreated obstructive sleep apnea, and then different management options for these patients. So obstructive sleep apnea is intermittent closure of the upper airway during sleep. It's usually behind the soft palate and the tongue. So normally when we sleep, we can move air and there's no problem. And people who have sleep apnea, their airway is closing behind their soft palate and their tongue on and off. So the air is trying to get through and it can't. So when it's coming through this narrow space, there's a lot of turbulence, and that's the snoring. And then when it actually closes, that's the apnea. And sometimes you can actually see this in somebody. Their partner will say, yeah, there's this loud snoring, then all of a sudden they look like you just stop. And they look like they're struggling to breathe. And then there's this huge snore and their airway opens and they're breathing again. And what we see in a sleep study is that they're breathing and then the airway closes and there's really no airflow, and this is the apnea. Or they're breathing and the airflow becomes really shallow and there's also a drop in oxygen, and this is what we call a hypopnea. So we add the number of these per hour of sleep, and that's how we get the apnea-hypopnea index, or AHI, and that's how we grade if someone has sleep apnea or not and how severe it is. So what happens as a result of these is arousals from sleep, so this disrupts sleep. So they're not getting good sleep, and so they're tired and sleepy during the day. And the other thing is that there's drops in oxygen with each of these. And that over time can lead to stress on the heart and the brain and lead to high blood pressure, heart issues, strokes, memory problems, and then all-cause mortality or death as well. So symptoms, so the typical ones we think of are snoring, witness apneas, arousals from sleep, waking up tired or unrefreshing sleep, being tired or sleepy during the day. But it can be things like impaired concentration, not feeling like you have enough energy, feeling irritable, feeling depressed, morning headaches. Those can be other symptoms attributed to untreated obstructive sleep apnea. So as a question to you, which statement is true regarding obstructive sleep apnea and hypertension? Treating obstructive sleep apnea has shown to have a significant decrease in blood pressure such that a patient can stop their antihypertensive meds. Treating obstructive sleep apnea can allow someone with resistant hypertension blood pressure to be controlled with antihypertensive medications, or both are true. Okay, so Actually, so treating obstructive sleep apnea can allow someone with resistant hypertension to have their blood pressure controlled with meds. But if somebody has hypertension controlled with the medication, treating OSA doesn't necessarily let them just stop their medication. So definitely if someone has resistant hypertension, difficult to control hypertension, so they're requiring 3 or more medications to control their blood pressure, screening them for obstructive sleep apnea symptoms is a good idea, because it could be that their hypertension will become controlled with medication. If someone's controlled on one medicine, treating their, I mean, we should, maybe we should still screen them and everything, but they won't necessarily come off their medication. Most of these issues are with moderate to severe obstructive sleep apnea, so an AHI greater than or equal to 15 is what's really associated with these health issues, and mostly in most studies it's more the severe apneas, which is an apnea-hypopnea index greater or equal to 30. The things that are associated with that are hypertension, in particular difficult to control hypertension, myocardial infarction, strokes, recurrent vascular events or recurrent MI or strokes, and all-cause mortality. And there are also some studies linking memory issues with untreated obstructive sleep apnea. So which is true? After the age of 65, the risk of obstructive sleep apnea increases independent of body weight. Females' risk of OSA is not changed by their menopausal state. Those of African American and Asian descent are at a higher risk of obstructive sleep apnea compared to those of European descent. A and C are true, or all are true. All right, great. Yeah, so A and C are true. So after the age of 65, the risk goes up independent of body weight. Studies have shown that the airway is just more collapsible at that time. And so you can have an elderly, normal weight patient who has severe obstructive sleep apnea. Females in general are protected from sleep apnea until they go through menopause, and then their risk goes up. So you can have a female patient, 25-year-old with a BMI 40, and they won't have obstructive sleep apnea. And we don't really completely understand it, but there's something about estrogen that's protective. And then certain backgrounds are at increased risk. So African background, Asian background are at higher risk for obstructive sleep apnea. So in terms of traditional risk factors, so BMI greater than or equal to 30, males are at higher risk than females until menopause, and then the risk is about equal. And this includes surgical menopause. So if a woman's had her ovaries taken out, her risk is a little bit higher. For women who have polycystic ovarian syndrome, where their testosterone level is a bit higher than what's considered normal, they're also at increased risk. Age 65 or higher is increased risk. Neck size is important. So for males, neck size 17 inches or greater, and for females, 16 inches or greater causes an increased risk, family history, and then certain backgrounds. So next we'll go into diagnosis. So, we diagnose it with a sleep study. That's probably not news to anybody. I kind of wanted to just go over what are the sleep study options and who should go for what type of study. So the sleep study options are the full attended PSG. This is where the patient goes to the sleep lab and sleeps overnight, and they have all the electrodes on their head and the airflow receptor and all the wires, and they're supposed to lay down in an environment that's not their home and try to sleep. The portable monitoring or the home sleep apnea testing was approved 5, 6, 7 years ago. And so this has kind of become the mainstay of how we try to diagnose obstructive sleep apnea. So as you can see, it's much simpler. There's a airflow detection device under the nose. There's effort belts. There's a pulse oximeter, which is on the finger. The patient goes home, puts the sensors on, plugs them into this box, and then sleeps in their own home. And so for a lot of patients, this is more comfortable for them than the in-lab study. So who should get a home study and who should go to the lab? So the portable monitoring is really recommended if you're looking to diagnose obstructive sleep apnea in uncomplicated adult patients that have signs and symptoms that show that they're probably at increased risk for moderate to severe obstructive sleep apnea. And we identify those patients as people who have the presence of excessive daytime sleepiness and at least two of the three. So sleepiness with either like loud snoring, witness apneas, gasping or choking, or diagnosed hypertension. There are other risk prediction models out there. There's adjusted neck circumference or the Fleming's score. There's the stop bang. So there are other screening tools. It's also important to know what's insurance going to pay for. So for example, with stop bang, you can have an obese male who snores and has hypertension, but if he doesn't complain of sleepiness, there's no observed apneas, at least in Ohio where I work, this insurance isn't going to cover the sleep study for that patient. So there are other predictors out there, but they may not correlate to what an insurance carrier is going to cover for a sleep study. So if they have excessive daytime sleepiness, usually they're good to go. And if they have observed apneas, for the most part, they're usually okay. But if it's that, well, they have high blood pressure and AFib and their BMI is 35, their neck size is 17 inches and they snore, but the patient denies having any symptoms, they may not get covered. So those are just some of the things that we have to deal with on the sleep medicine side when we're evaluating patients for obstructive sleep apnea. Who should we not do? So really the person that we do portable monitoring in is someone who we're pretty sure they're at high risk for obstructive sleep apnea. Those are the patients who are really studied for the validation of the portable testing. Those are the patients that really it's recommended for. It's not recommended if you're looking for central sleep apnea, hypoventilation, or some other reason for their sleep-related hypoxemia. The reason being studies just haven't been done to validate home testing on that patient population. So if someone has significant cardiopulmonary disease, like significant heart failure, respiratory muscle weakness due to neuromuscular conditions like ALS, muscular dystrophy, history of stroke or opiate use where you're worried about central sleep apnea, those patients should go to the in-lab because we get more information. We do look at their sleep, we look at the different stages of sleep, how that relates to their breathing. You can do testing with CO2 in lab. You can't do that in the home study for if you're looking for hypoventilation. So for that reason, these patients should go to the lab as opposed to a home study. If you're looking for something else other than a sleep respiratory disorder, so you're looking for narcolepsy, movement disorders, parasomnias, those patients should go for an in-lab study. If you think that there's something going on with the home study may not be accurate, there's someone who has severe insomnia, they're like, I only sleep 2 or 3 hours a night. The portable monitoring may not be great because we don't measure their sleep, we only measure their breathing. And so if they're awake the whole time or the majority of the time, we can't tell, and it can look like they don't really have sleep apnea, but the truth is they only slept for 2 hours. So that whole reading wasn't really total sleep time, which can lead to an underestimation of the presence of sleep apnea. Or if there's environmental or personal factors where they couldn't do the home study. So maybe they cognitively aren't able to put the sensors on themselves and there's no one at home to help them. If their home environment is very disruptive and there's no way they can get a good study at home because they have too many environmental factors that may be disruptive, then maybe that person should go to the lab instead. So just to know with home testing, it can underestimate the presence of severity of obstructive sleep apnea. So again, we don't measure sleep. So if someone's awake a lot, we can't tell, and you can get false negatives. There also can be technical issues. There's a technical fail rate of up to 12%, false negative rate of up to 17%. So if you have a patient who you think is at risk for moderate to severe obstructive sleep apnea, they have excessive sleepiness, they have snoring, they have gasping and choking, their home study is negative, then that person should you could do either a repeat home study or send them to the lab. Most often we just send them to the lab to ensure that we're not missing anything. When we look at the sleep study, we identify sleep apnea, we grade it by severity. So we calculate that apnea-hypopnea index, which is the number of apneas and hypopneas per hour, total hours of sleep of the study. If it's a home study, it's over the total recording time. If the AHI is less than 5, that's considered normal. 5 to up to 15 is mild, 15 to up to 30 is moderate, and 30 and above is severe. And again, the moderate to severe, mostly the severe apnea is what we worry about when it comes to cardiovascular health. So as a question to you, who should have their obstructive sleep apnea treated? 25-year-old male with severe OSA and fatigue with no other health issues, a 55-year-old female with mild OSA, hypertension, recent MI, who mainly does not feel sleepy and had to study for what few witness apneas and snoring and by her partner are both A and B. All right. So most people picked A and B. All right. So the answer is the 25-year-old male, and I'll go over why here in just a minute. So the recommendations for treatment are if you have moderate to severe apnea, you should be treated regardless of symptoms. And that's because we worry about the cardiovascular effects on the heart. If you have mild, so 5 to 14, you should be treated if you have symptoms that bother you. But mild sleep apnea has not been shown to be associated with things like hypertension and cardiovascular disease. So if someone like the patient that was described before, they have mild apnea, really they went there for snoring and some apnea is noted by their partner, they're not really invested in using a treatment, they're not bothered by their symptoms, they don't want to go forth with using CPAP or anything else, that's not someone I'm going to push to use it. The 25-year-old who's feeling sleepy is the one who should be treated. So again, mild apnea, we offer them the treatments. We say, you could do even a trial of treatment. Maybe you'll find benefit, even though you don't complain of a lot right now. There are some people who do have more energy after they're treated that don't recognize that they were tired. But if someone's really adamant they don't want anything, I don't push the cardiovascular issue with them because that hasn't been shown with mild apnea. Whereas someone who has moderate to severe, I'll push more about also worrying about their cardiovascular health related to untreated sleep apnea. So in terms of treatment options, so there's behavioral modification, which weight loss and positional therapy. Weight loss can help improve apnea. In some cases it does resolve, not always, because sometimes it's not all weight. It might be genetics, it might be upper airway anatomy, or a combination of all of this, but weight loss can definitely help. If someone's apnea is mainly when they're on their back and not when they're on their side, they can do positional therapy where they try to sleep on their side. They can buy devices that keep them on their side, or you can just tell them, put some pillows behind you to try to keep on their side. More of the interventional treatments are continuous positive airway pressure, CPAP, which is the most common one. There's also oral appliances, upper airway stimulation, and then some upper airway surgery. So I'll go over the first three, the CPAP, oral appliance, and the upper airway stimulation with you guys here. The upper airway surgeries, those are things like UP3, where they shave off some of the palate and the uvula and take out the tonsils to open up the airway space. The long-term efficacy for that is less than 50%, less than 40%. So it's not something that's really done a whole lot anymore. There are more aggressive upper airway surgeries like hyoid suspension, where they kind of push and pull the tissue to open up the airway, and mandibular advancement, where they can kind of bring the jaw forward, which have a little bit more efficacy. But there are some of those patients, especially with the hyoid suspension, that over time their tissue grows back and their apnea comes back. So I would say probably CPAP, oral appliances, and upper airway stimulation are the three main things that we kind of discuss with patients, but upper airway surgery is still there and still on the table if those other three aren't really applicable to the patient. So CPAP is the gold standard. So the patient wears a mask, attaches to a machine with a hose, and it blows air. It's like a vacuum in reverse to keep the airway open so it doesn't keep closing. So it acts as a pneumatic splint. It's the most effective therapy. So there is no therapy as good or better than CPAP. It's the most effective therapy, and that's because it blows open the whole airway. Most of the other treatments are treating some part of the airway closure, but it's not treating the whole thing. So that's why CPAP is the most effective, but it is difficult to use. And there are a lot of people who can't use it despite our intervening on multiple things, changing masks and things like that. They still can't use it. And so it's important to know that there are other things out there too. So oral appliance is something else that's gaining popularity for obstructive sleep apnea. So this is an example of it. Patients go to a dentist. A customized device is better, where they make a mold to their mouth. And there's different ones. This one, I think, is a tap where they turn a key here and it moves the lower jaw forward. There are others that have hinges on the side that move the lower jaw forward. And basically the dentist has the patient advance the lower jaw more and more forward to try to help and hold the airway open. The AHI reduction for this is not as much as CPAP. So there's about a 60% reduction, and this is just an example of a study. This is kind of the baseline of their sleep apnea here, and then the short-term follow-up, 2 to 7 year follow-up, and then most of them didn't follow up after that. But there's a decent AHI reduction, with most of them having an AHI less than 10. So it may not be less than 5, it may not be normal, but there's a significant reduction. So it's about 60% reduction. But the adherence has been shown to be higher with oral appliances than with CPAP. So it's easier for patients to tolerate. For severe apnea, the Epworth Sleepiness Scale has improved. Mild to moderate, the effect on the Epworth. And the Epworth is a sleepiness scale we use to objectively gauge if someone is sleepy. So it's different sedentary situations. Would someone fall asleep? The patient fills it out, zeros, they would not fall asleep. 3 is a high chance they would. And then the score is 11 or higher, that indicates excessive sleepiness. So if you see that wording, that's what we use in clinic, and that's what's used in a lot of studies to gauge sleepiness for sleep apnea patients. So the Epworth gets better, the adherence is usually pretty good. The AHI reduction isn't as good, but if they can use the oral appliance 100% of the time and they can't use CPAP at all, then a 60% improvement is better than 0. And so there is an argument that a treatment that a patient can use may have the same or more efficacy than a treatment they can't use. The hypoglossal nerve stimulator was FDA approved, I think it was in 2017. So it's something we're doing a lot here at Ohio State. So basically what this is the hypoglossal nerve stimulates the genioglossus muscle, which is the biggest tongue muscle. And so what it does is during sleep, when the patient takes a breath, there's a sensor lead that senses the breath. It activates a stimulator lead to stimulate the hypoglossal nerve, which then activates the genioglossus muscle and pushes the tongue forward. And so when it pushes the tongue forward, it also pulls forward the soft palate and stiffens up the upper airway muscles and causes increased patency or upper airway opening during sleep. And so basically this is going on, the tongue moving in and out during sleep to treat obstructive sleep apnea. So there's a generator here, a sensing lead, a stimulation lead. This is an outpatient surgery, and the patient will have to go back in 10 years for a battery replacement. And what they do is they turn the stimulator on themselves at night. We adjust it to certain settings that we think treat the apnea, and the patient turns it on every night to treat their sleep apnea. So it's actually now approved for age 18 and higher. It's approved for moderate to severe obstructive sleep apnea, so AHI of 15 to 65. They have to have less than 25% central apnea. So if they have a lot of central apnea, this isn't going to work for them. Body mass index less than 32 is the patient population that responds the best to this, but it's been implanted in up to 35 and been successful. They're intolerant or can't use CPAP, and they have a drug-induced sleep endoscopy. So what that is the patient is sedated a little bit. We go in with the scope and see how the airway closes, and I'll show you in the next slide what we're looking for. If there's an anterior or posterior closure, that patient will respond to the device. If the closure is more concentric, meaning the whole area is closing down at one time, they won't respond to the device. So they have to have that first to see if they're a candidate. If they have central apnea, they shouldn't get this. If there's some sort of neurological disorder where the hypoglossal nerve may not be intact or some upper airway issue, then they probably shouldn't get this. MRI, there's limited MRI capability. They could get head, neck, and extremity MRI, but they cannot get chest or abdominal MRI. So in the drug-induced sleep endoscopy, this is what we're looking for. This is done by the ENT surgeons. So we're looking for this anterior posterior closure. If they have a complete concentric collapse behind the soft palate, they're not going to respond to the device. So they have to have this before going forth with the implant. So the initial studies show that it's pretty successful, 70–80% reduction in apnea-hypopnea index. The ADHERE registry is a registry of implanted patients after FDA approval. And this was published, this was published, I think, in 2019, yeah. So they had a little over 1,000 patients in this registry. and they're down to 640 at 6 months and 382 at 12 months. But what they showed was the baseline AHI was 32.8. It was down to 6.3 at 6 months and 9.5 at 12 months. So again, a pretty good success rate. And then if you kind of look at the way those numbers look now, I would say the average AHI reduction by this device is about 60%. If their BMI is a little bit higher, it may be close to like 55%. So again, a good reduction. Is it complete treatment? No, I would say most people go from severe to mild, and most people find improvement and they like it better than CPAP. And so again, in someone who has severe sleep apnea who can't use CPAP, this is probably a decent alternative. So this is the next case presentation. So this is a 55-year-old male with severe obstructive sleep apnea. His AHI is 55, comes in with inability to use his CPAP. So this is a pretty typical case that we'll get in sleep clinics. So he was diagnosed 2 years ago and has symptoms of snoring, daytime sleepiness, witness apneas by his wife. So with the CPAP, he feels claustrophobic and anxious. He's tried a lot of different masks. He hasn't found one that he particularly likes. He doesn't feel that the pressure is an issue. He thinks it's tolerable. He doesn't think he has a lot of issues with dryness. He has trouble falling asleep with his CPAP, and if he does fall asleep, he'll wake up with it off and doesn't even remember taking it off. So this is a very common scenario. So his PCP sending him back to sleep clinic to see what can be done to help him use his CPAP because he has severe sleep apnea. He's symptomatic, and he's tried numerous things and he's still struggling. But the patient wants to treat his apnea and he's motivated. So as a question to you, what is the general CPAP adherence rate? So it looks like there's two. So they put up both. So the first question is what's the general CPAP adherence rate? And the second one that's after that is what's shown in studies to improve CPAP adherence. All right, great. So less than 50% is definitely the adherence, and then all of the above. So that is true. Well, studies have shown that using BiPAP can help. If someone has pressure intolerance from CPAP, switching to BiPAP can help. If you just randomize someone to CPAP or BiPAP for sleep apnea out of the gate, neither one has higher adherence. But if someone has issues with pressure, switching them to BiPAP might help. If someone has dryness, adding heated humidification can help. But the thing that's been shown to help by and large with adherence is patient education. So there may be a certain subset that respond to this and a certain subset that respond to that. But when you look at overall what has been shown consistently in studies to improve adherence, it's patient education. So the patients who have investment in their treatment, they understand the reasons why they should be treated. They are troubleshooting early, either with their sleep physician or otherwise, to try to help with whatever issues they're having because they're committed to really getting to use the CPAP. That's really what's been shown. And sometimes that doesn't always come from us as a sleep medicine physician. So I can sit there and tell them, you really should use this. This is the reasons that we use it. But sometimes when that education comes from others, the primary care doctor or their therapist or some other healthcare provider who they have a strong relationship with, who they've been seeing for a long time, who they trust, and they're educated about why we should treat sleep apnea, what are the things that we can do, there are other options, it's worth it to go back and talk to the sleep doctor about these different things, that really can make a difference. And the patient education a lot of times may not come from us because a lot of times half the people probably come to sleep clinics that are referred to us, and then who knows how many of those actually even come back, because sometimes once they thought about it, they're like, I'm just not going back there. So that might come from other providers and other healthcare people that they're interfacing with. And so it's important to, if you have patients with sleep apnea or there's, some element of that, kind of talking to them about it and not just saying, okay, we'll go back and talk to the sleep doctor, because maybe hearing that from you is going to make a bigger impact for them to even come into the sleep clinic to begin with, or to come back if they've been struggling. So I'll kind of put this to Dr. Phillip. We see this a lot. We've tried everything mechanically for the patient to improve them with CPAP. Sometimes it's a claustrophobia issue. Sometimes it's a motivation issue. Sometimes it's like the patient's just like, I don't even know what to do. And I know that there are some studies looking at behavioral interventions for these patients. And so I'm just curious, from your standpoint, how would you approach somebody like this that has done everything mechanistically that we think we can do, wants to use it, but just really can't seem to be able to get used to it?
Yeah, and I think sort of CPAP adherence or compliance is something that if you're sort of in a good integrated care setting, you'll likely get a lot of referrals for, and as a behavioral health provider. And there are cases where there is true mask-related anxiety or phobia. Some people, especially people who have a history of trauma of different sorts, like emotional trauma, having something covering their face or their mouth can be extremely anxiety provoking or triggering. Also, people who are already keenly sensitive to changes in physical sensation or breathing, people who are prone to panic disorders, for example, having anything that feels like it's changing your breathing or your heart rate, or anything like that, can really sort of contribute to those spirals. And there's also times where, depending on the type of mask, if there's a mask that gets in, I don't know if hopefully I'm not, if there's a mask that gets in the way of your line of sight, that can also be particularly triggering for some of the patients I've had. So there are manualized protocols for CPAP desensitization. So basically, gradually working folks towards getting more and more comfortable using the mask, wearing the mask, and then keeping the mask on. It's sort of different hierarchies. So and I'm happy to, I can, if anyone's interested, I'm happy to kind of share out a few articles and things about that. It's actually not terribly complicated. You can even start it in the office or through telehealth. It's as simple as having people start wearing the mask really during the day, even before they're sleeping, really just desensitizing. But I think sometimes we hop to that a little bit too early, and I'm glad that you mentioned like motivation and things like that. What I've seen, and I think there is also some research backing this up, is that the the early experience using the mask and using the CPAP treatment is so predictive of how long term and how sort of compliant people are with the regimen. So I often will partner with the primary care docs or with the sleep medicine folks, especially when we know from the outset that a patient has some hesitancy, to really work with them on motivational enhancement and addressing those barriers early. And I'll be honest with my patients about it. I'll let them know, I'm like, to help build up their motivation, I'll say, it's evidence shows that what happens in these next couple of weeks is going to change your trajectory. If we can put the work in and really try to be reliant and reliable in how often and how long we're using the mask for, it's only going to increase the likelihood that you're going to have success. But I find it's important for patients to have those early wins and feel the difference, because our people who lived the folks who lived experience last month highlighted, for some of it can be life changing. It's like night and day, and no pun intended. Like, it's so profound. So work with them on that, on the desensitization, on really motivational enhancement. But I mentioned this last time too, that the best thing I did as a psychologist was to, a couple of times where I had the capacity, was to accompany my patients to their visit to the sleep clinic where they were fitted for a mask, to understand the process, to understand some of the things you mentioned, even about the moisture, humidity levels. Because you're right, the information needs to come from multiple sources. And I'll sit in the class with them, and we both hear the same things, but we take away totally different aspects of it. And so reinforcing those key components is really is so important. Sometimes we'll have conversations, and to me, it'll feel like it's the first time we've ever talked through like the importance of how to wear the mask and the different types. But I know that's been discussed before, and we see that with diabetes and lots of other things. So yeah, absolutely. So I'm not going to go on too much longer, because I know there's also some great questions, but those are key factors. And actually, I sort of made myself almost a key informant around sleep apnea, and I often will screen folks for using like the stop or things like that for some of the real blatant signs of sleep apnea. And I did a little like test once when I was in primary care, and I found that over 90% of the folks I referred for sleep study actually did have sleep apnea, and obviously there's some degree of error there, but my point is really it's worth folks who are behavioral health providers asking some of these questions and listening for that in addition to insomnia, because it's not always picked up even when the referral is made by a primary care provider. That's my PSA.
Right. And then there's also the kind of the point where maybe we should think about, CPAP just may not work for this person, and having a threshold to kind of talk about other things and not be so narrow that they have to use the CPAP. Like I said, it's a treatment that's 60% effective that they can use is better than a treatment that's 95% effective that they can't use. And just some other conditions to consider. So again, a patient who can't sleep, a patient has insomnia, looking for things like restless legs, the urge to move their legs at night, the movement, the urge is relieved by movement, and it's the reason they can't sleep. So some people have restless legs, but it doesn't bother them enough that it bothers their sleep. But if it does bother their sleep, then you want to check things that we use, check a ferritin, which is an iron store level, and look for a level of 75 or higher. So there's a thought that the restless legs is due to some iron deficiency in the brain, but we can't test iron in the brain. We can only test it in the blood. And so a level of 75 or higher indicates a good central nervous system level of iron. And if it's less than 75, then we treat with iron supplementation. So even though they're not considered anemic unless it's less than 10, for restless legs, we want it to be 75 or higher. And you can give that with vitamin C to help improve absorption. Dopamine agonists are something else that we use to treat restless legs. So ropinirole, pramipexole, just something to be aware of with these medications, that there's something called augmentation and rebound that can happen, meaning you start the medication, initially it works, then the restless leg symptoms come earlier and earlier, or it spreads to other areas. Now it's happening during the day. That's augmentation. Rebound is happening in the morning. The patient will say, oh, the medicine's wearing off too early. It's happening in the morning. So that's not a feature of the restless legs by itself. That's an issue with the medication, the dopamine agonist in particular. And so if the answer is to increase the dose, that problem is going to get worse. Because the thought is you're having this dopaminergic activity, and then there's a drop in the medicines out of their system, and this is what's causing the augmentation and the rebound. And so the higher the dose that you make, the more that disparity, the worse that's going to get. And so if someone doesn't know that, they'll keep increasing the dose, they'll have them take it multiple times during the day, and all of that's just making everything worse. So that's probably someone who should see a sleep physician about different medication avenues rather than just increasing the medication dose. Circadian rhythm disorders. So this is where someone's sleep clock is out of line with their environmental clock. The most common is delayed sleep phase. You see that in teenagers, young adults, where naturally they want to sleep at 2 or 3 and get up at 10, but they have to get up at 7 or 8 for school or work, and they have a hard time falling asleep earlier, and they can't get up earlier, and they're sleepy in the morning, and they get a second wind at night and can't fall asleep before 2 a.m. So something to think about in someone who can't sleep. So there's some references here if you want to read about that. And then for patients who are sleepy, always look at their sleep hours. Insufficient sleep is so common. People think 5 or 6 hours is enough. It's not. So always look at their sleep hours, look at their medicines. When people referred for narcolepsy that are on multiple sedating medications, it's not narcolepsy, it's the medication. So kind of looking at those things. And then if you want to learn more about narcolepsy or idiopathic hypersomnia, which is another condition that can cause sleepiness, there's a reference there. And so just some key points for the whole thing. So there are alternate treatments for obstructive sleep apnea for those who can't tolerate CPAP. So make sure to bring that to the forefront with your patients. We treat mild apnea if they're symptomatic. We don't push them about heart disease and things like that if they're mild. It's symptomatic treatment. If you're seeing patients with sleep issues, sleep diaries can be really helpful. And the earlier you intervene with people who are having sleep issues, especially insomnia, the better they're going to do. The longer they suffer with insomnia, the harder it is for them to get over that anxiety. So if you can talk to them early about good sleep tips, it's going to help them tremendously in the long run.
So I think we're into our sort of final section here, and just we've answered actually a lot of the questions that have been coming up in the discussion and sort of as we've talked through here, but there's a couple more I just want to highlight in our final few minutes. Dr. Khan, there was quite a few questions around some of the other over-the-counter sleep aids, things like ZQuil or Tylenol PM. I've certainly had a lot of patients who have turned to those, prior to like any other sort of prescribed intervention. What are your thoughts about those? Any messages that we should be giving our patients around that?
So typically those, the sedating component is diphenylhydramine or Benadryl. So the studies show that actually the tolerance to that builds up pretty early. And there can be a lot of hangover effects. So grogginess in the morning, morning headaches, difficulty getting going. And for patients who are elderly, it can cause cognitive issues. So, if you're having, trouble sleeping here or there and you want to use a Tylenol PM like a couple times a month, fine. But I wouldn't rely on that as a regular sleep aid, and I would start looking at other things to improve sleep if it's something someone's having to use regularly.
Yeah, great points. And I think that's like oftentimes we see whether it's prescribed or not, a real over reliance, and that's where that sort of like talking about the quality I think can be helpful. What about we've talked a lot about adults, and this is a little bit, I'll say, out of my area of expertise, but toddlers. There was an interesting question about using melatonin, kind of low doses in toddlers or children. Is there any sort of evidence around that or precautions or?
So, in kids, there are some precautions. It could cause precocious puberty and things like that. I would definitely consult with the pediatrician before giving something like that to a child for sleep. They do sometimes use it at Children's Sleep Center in kids who have autism or autistic spectrum disorder because they have a lot of sleep issues. But, for developmentally normal child, probably looking at kind of the sleep routines and those kinds of things might be better. And then if that's still a struggle, talking to the pediatrician first, is what I would recommend.
Yeah, I think that's a great idea. And then, and this we'll wrap with this question, but you did provide your email address, which we had in our earlier slide. And actually, Jaime, if you can bring up our final slide, we'll include our contact information as well. But and I think this question I like because it speaks to the integrated nature of care. But in situations where people perhaps have a chronic medical condition unrelated to sleep particularly, but the medication itself is either causing some sort of hypersomnolence or excessive sleepiness or insomnia, that's a little tricky to navigate. Any suggestions for that or starting points?
So that's always difficult. So you're saying like someone's on a medication causing insomnia that they're using for a different medical
Yeah. Or we know like a lot of, like, for example, pain medications or even psychiatric medications cause a lot of sleepiness. And so I know, like, do you add on a stimulant? Like, what's the?
I think it becomes a little bit tricky. So I think one thing, again, looking at what's the structure of the sleep schedule, just making sure all of those are intact, like there isn't something behavioral going on that can be modified. And then just having a conversation with the patient and then relying with with their primary care or their psychiatrist and whoever's treating them, that probably some of this is due to medication. And so it might be that we just have to live with some of this sleepiness. So if there's issues like safety with driving and things like that, and then maybe we'll say, okay, we'll give you a little bit of stimulant that you can use before you drive. Depending on their job, maybe we'll try if their psychiatrist doesn't think it's going to cause a problem with their mood disorder, like if they have bipolar or anxiety, definitely want to make those worse. Then maybe we would do that, but understanding the reason is the medication. They don't have a primary sleep disorder, it's the medication or what have you. And we're just trying to improve quality of life and just making sure that you're all on the same page in terms of expectations of the treatment and learn that there's going to be a balance. And when you're trying to counteract the side effect of one medicine with another, you never, that may not always work out well. So just having that conversation and being with the patient on the same page about expectations. But I think what you do varies from person to person. There's probably not a cookbook recipe for everyone, but definitely looking at lifestyle and sleep behaviors, making sure all those are optimized. Trying to, sometimes in medicine, they can take it just at night and not during the day. Sometimes that can help. Like, can they be changed around with the timing to help the patient, or just recognizing it? Sometimes patients don't realize, oh, gabapentin can make you sleepy. I didn't know that. Like, I don't really need to take it during the day. I'll just take it at night then. So even just talking to the patient, there may be things they can think of on their own when they realize how the medicines may be affecting them.
Yeah, I really appreciate that really patient-centered approach, right? So like working with them, they may have the answers themselves actually better than we do sometimes. I love that point. And I think that's actually a great way to close out. So Dr. Khan, thank you so much for your time. This has been great. This is the kind of thing I wish I had gotten earlier. I wish I had gotten this in school. We're just not, we're not there yet. So hopefully this was beneficial for folks in the audience. Really just, again, honored to have you join us, and thank you for going through. And this is really stuff that we need to know. And again, we can use this information to keep our patients in the driver's seat of their care. And that was the message from, from our panel of folks with lived experience last month too. They want to be asked these questions, and they want to be asked them, that we want to have these conversations not only during their medical visits, but also in behavioral health. We know that there's connections between mood, cognitive functioning, all that, and sleep. So um, thank you so much. Thank you for sharing with us. Thank you everyone in the audience for joining us with us, sharing your experiences, your jobs, the work you do. It's very inspiring. So join us for our last episode coming up in May. If you're not already signed up, you can sign up and see also past episodes at pcdc.org/sleep. And actually, if you yourselves are in a healthcare provider role, and have thoughts about the sort of what about us? How do we take care of our own sleep health as healthcare providers? Let us know. We might be able to feature you on our next and last episode. So Dr. Khan, thank you again so much. Thank you to SAMHSA, the National Council for Behavioral Health, our organization PCDC, and our many partners in this work. It is an honor to continue this conversation, and we'll see everyone for one last time on May 5th. Thank you.
Thank you.